We have an amazing session for you today, a lot to cover, so I'm not going to do too much of an introduction, but I am excited to tell you about Dr. Elizabeth Ekren, who's going to be hosting today's session. So without further ado, I'm going to pass it to Dr. Ekren.
Thank you so much, Cody. First of all, I really want to say thank you so much to everyone for being here. I think we have a great, diverse representation of industries and sectors, which really makes for a valuable session. So I'm so grateful that you are all here today. I am going to start by just giving a very brief introduction, quick snapshot of who we are at THRC and why this project matters to us. So, the Translational Health Research Center, or THRC, is one of 9 university level research institutes at Texas State University. We focus on impactful, innovative, interdisciplinary health research that is done with communities in mind. So, we work closely with faculty, students, industry partners, community partners on a wide variety of things, ranging from virtual learning series like this one to providing free data analysis and GIST trainings, to conducting collaborative research initiatives with community organizations, just like those in attendance today. I am Dr. Elizabeth Ekren, and I will be facilitating today's session as the lead researcher on the project. I am a research associate here at THRC, and my background is in development sociology. A lot of my other work at THRC focuses specifically on how qualities of people and the places they live shape health outcomes, and how understanding these dynamics can help us design better interventions. I was going to be joined today by my colleague and co-lead on this project, Dr. Shadi Malecki, but she had an unexpected medical issue come up. But I am joined today by one of the program officers with our sponsoring organization, Mr. Kevin Lambig from the T.L.L. Temple Foundation. I am so excited he's also here with us today. So I would love it if Mr. Lambig might just quickly introduce himself and his interests, so that you might connect with him in the chat if you have any questions for him. So, Mr. Lambig.
Hey, Dr. Ekren, thank you very much, everyone. Again, Kevin Lamming, the Senior Program Officer for Health at the T.L.L. Temple Foundation, located in East Texas. I see several folks that may be very familiar with our work on the chat there. So welcome to all of our possible grantees and people that we work with every day. You know, I'm the Program Officer for Health, and my goal every day is to ensure that East Texans are healthy and have access to quality health care. Well, that's a big, wide scope of things to do and to take care of. And it's always important to look at data whenever you're making decisions for a philanthropic gift or to help support an organization. But the important thing about data is that it only tells you one story. So you sometimes have to disaggregate that data to get a better picture of what it is that you're funding. And so when we talk about rural health, well, if you've seen one rural community, you've heard the saying, you've seen one rural community. Well, I'm located in the piney woods of deep East Texas. Today, I actually sit here in rural New Jersey, awaiting the birth of my first grandson. And so rural New Jersey, as I found out in the last 5 days, is a much, much different than rural East Texas. And so it's great to work with Dr. Ekren and her team as they looked at the data from our East Texas region and others to kind of see what it is that's important to East Texans, what the deficits are, what the needs and what the opportunities are for us as a philanthropic organization, as we partner with many of you to ensure that East Texans are healthy.
Thank you so much, Mr. Lambig. That actually kind of transitions great into kind of what we can expect from this session today. So I will be sharing a little bit more about this specific research we conducted in East Texas, looking at rural health from a community-oriented perspective. I will walk through what we did and a few kind of high-level findings, but more importantly, I actually kind of want to talk about this project more as a case study in community-oriented research, and how work such as this can give us all a foundation for kind of smarter, more informed action. So I will spend about 20 minutes doing that, and then we will open up for a discussion with our panelists, who are all project collaborators, but also have their own wealth of experience in rural health and public health work in general. And we'll kind of talk about the takeaways and themes with them. And so my goal ultimately is that, you walk away not knowing just a little bit about what we did in East Texas specifically, but rather that you kind of have some practical ideas and takeaways that you can apply in your own context. So I'm going to start by just giving a brief picture of rural health in Texas, which shaped the context for this work. I think as many of us understand acutely and kind of why we're here today, we understand that rural Texans face profound and well-documented health disparities. And this is the background against which most of us work. So for example, rates of specific diseases, poverty, uninsurance are higher in rural areas in Texas than in the state overall. And rural counties are generally more likely to be healthcare shortage areas and face accelerating facility closures than in the state overall or in urban areas in some cases. If you would like a little bit more information just about kind of rural health disparities in Texas in general, you can go ahead and scan the QR code in the slide. T.L.L will also post a link to a chat just on some other research our center has published on health disparities in Texas that you might find useful for your context. But the takeaway here is really that where you live has a profound effect on your health. And that's not just because of the structure and resources of the places themselves, but of how these and other dimensions of rurality shape personal health behaviors. And really, I think that's actually the first key takeaway that we can all reflect on today in our context where we're working. And that's really that rurality is much more than a label. It is very multifaceted. Rurality is geography. So it is things like lower population density, vast physical spaces and distances, physical remoteness. But rurality is also structure and resources. It often means limited infrastructure, fewer social services, thinner professional networks. Rurality is also culture. So it means people who share a particular community ethos, often deep ties to their local area, sometimes maybe wariness of people outside their communities or distrust of certain systems or institutions. And finally, rurality is, administration, it's politics, it's the formal delineations like from census or RUCA codes that determine who qualifies for certain programs or funding. And so really this diversity of rurality frames everything that we're going to talk about today, the background of our work, the background of, I think, a lot of your work. It shapes how we design interventions, how we target resources, and how we measure success. And I think once we see rurality more than just a place, so as that intersection of geography, structure, culture, systems, we're really reminded that improving rural health requires a lot more than just improving services. It requires strategies like community-oriented research that connect these local realities to broader trends. And this also helps in turn to kind of build trust in these places and spaces where people live and are seeking care, and kind of engage communities and residents as partners in kind of building better solutions together. So I think despite this pressing need for a better understanding and even kind of the growing attention to the rural health issue, we still have surprisingly little data on how people actually experience health at a truly local level. And these insights can just be very hard to capture. And this challenge certainly motivated our work. So we set out to create a data set drawn directly from rural Texans to kind of understand a little bit better how this local context shaped health challenges. And secondarily, we really did want to build relationships, I think, that could spark some meaningful change kind of in the mid to long term. So, from the start, this case study or this project wasn't just about data gathering, but it was about trust building, collaboration building, and really kind of opening doors, I think, for sustained action with our community partners, a few of whom you will meet in the panel a little bit later on. And so kind of to share, I think, some just encouraging outcomes from this type of cross-sector work, I would love to just kind of share that with you. So beyond the project report that we produced for this project and this ECHO series, our collaboration has already led to one jointly authored academic paper that is being processed to get under review with a journal as we speak, a major grant proposal under development, and two others that have been submitted, and also a follow-on project that has kind of spun off from this, actually involving interviews with local community leaders that is underway. And so I think kind of outcomes such as this really can show how research and sector community partnerships can generate both knowledge and momentum to kind of keep change going. So with that foundation in mind, I would like to kind of turn to the study itself to see how we approached this. So through the support of the T.L.L. Temple Foundation, we were able to reach more than 400 participants through an online panel survey. All came from rural zip codes across Public Health Region 4-5 in East Texas, and all the places that we reached were medically underserved areas. So we do feel like we were able to kind of access a very specific population of people that often does experience a lot of challenges accessing healthcare when they need it. In a second phase of this study that we won't talk about today, we actually worked directly with our community partners to expand the reach of our data collection even further. So we were able to partner with Northeast Texas Public Health District, as well as some of the medical staff at UT Tyler, to do some in-person survey recruitment. So even though we aren't talking about that today, I did want to share that as an example of how these partnerships can also kind of help scale work for even further reach. So as part of our survey collection process, we collected data on a lot of different topics, including demographic and social determinant of health information, information on health status, care-seeking behavior, geographic availability of different services, and trust in health information and health systems. So we didn't design this project or this sample to kind of be a perfect statewide representation. We really wanted it to be locally grounded, very digestible, and very action oriented to kind of just help understand or help local partners understand the kind of local dynamics a little bit more, but also serve as a blueprint or as an example for other organizations maybe wanting to conduct similar types of work. So if you would like to read the full report or follow along with some of the findings as we discuss them next, feel free to scan the QR code in the slide. So Lolly will put the link to our project report in the chat if you want to go ahead and download it. But as I am sharing some of the findings from the report on the next slides, I don't just want to present them to you kind of as numbers or as statistics, because I think maybe that's not really the point. I think the point that I hope to make is to show how these types of results and how findings from community-oriented work like this can do a few important things. And I briefly alluded to them earlier, but I'll go over them again. First, I want to show how this type of data can connect local perspectives to broader state and national trends, kind of helping us to see where those patterns match or don't match local realities. The second thing I'm going to talk about is kind of how these types of findings can show where local trust lives, where it breaks down, and then kind of show how that can give us some entry points to maybe build stronger local connections and partnerships to scale our reach and scale our impact. And finally, I just hope to highlight kind of why meaningful community engagement and this cross-sector work is essential, because really if we don't understand how people are experiencing their challenges on the ground, it's very difficult to design relevant interventions that work. So with that framing in mind, we can look a little bit at what we found. So some of what we found in our project actually did echo broader state and national kind of trends in rural health challenges. So in our case, people did frequently cite things like high cost of care, transportation barriers, and provider shortages as the top challenges in their communities. But what was interesting was that these dimensions weren't isolated. So cost, access, and availability often intersected across questions. So we kind of saw these similar types of answers intersecting across questions and in some of the different analyses that we did, really showing how they all kind of compound one another. And this does align with what we see in other rural regions, but I think the local data added contextual specificity that we just wouldn't be able to confirm in kind of broad reports. I think another very useful insight we were able to get was kind of about the perceptions of what problems mattered most to people. So maybe we, from our vantage points as either clinicians or academicians, or where we are in our context, we might assume things, say like hospital closures or provider shortages, are maybe the biggest worries. But when we asked people directly, we got a little bit more kind of nuanced context about this. Specifically, in our case, affordability and availability emerged very frequently together as a pressing barrier, as I had mentioned before. We found it particularly useful to kind of see how people experienced barriers and challenges a little bit differently when looking specifically at the type of care that they were needing but couldn't get. I think these intersecting experiences and this specific information, again, kind of tell us how people are actually experiencing access challenges. And if we don't align our interventions or maybe our ways to expand access with what people are actually experiencing, I think even our best intentions can kind of miss the mark. And I think these kinds of more specific, informative findings are helpful in what I think is going to be a upcoming kind of resource constrained environment. So we can see how we can just be good stewards of our resources and really direct them to where change kind of needs to happen. Specifically, we did see in our case some very strong alignment between our local data and kind of state trends for mental health care access in particular. Participants rated mental health care as the hardest type of care to get when needed, and this was even more difficult than emergency or primary care, and even more difficult in general, or generally fairly difficult even for people living in remote areas and kind of experiencing other dimensions of socioeconomic hardship. And so this does mirror kind of HRSA shortage designations, which show a very high need for mental health providers across East Texas in particular. But the long and the short is that these local experiences confirmed what the broader data told us and kind of added that lived context that helped us to understand, yes, people are experiencing these challenges, they are feeling them in their day-to-day, and we kind of were able to see that with more confidence than just relying on broader data alone. So I think from there, the next piece is about trust, because knowing what the problems are kind of just the first step. And so really to design solutions that people will use and find relevant, I think we need to see and understand, who in communities people trust, where that trust lives, kind of where it breaks down. And then we can better understand how we can partner with one another across sectors to maybe increase reach and kind of create more resonating messages and activities. So we did find, in line with broader trends, that trust operates at a very local and personal level. So people overwhelmingly said they trusted providers they see most often, friends and family they talk to in person. Trust in local leaders was a little more mixed, and then the trust in broader systems or national leaders was lower, especially among people who were in more isolated rural communities. So in the remote rural communities, people who reported unemployment or people who reported lower education levels. And I think this really matters because it shows that building trust for improved health information consumption and positive behavior change really does need to start close to home in neighborhoods, clinics, churches, local gathering places. And these are all the types of organizations that many of us are working in and many of us already represent. So, if trust can kind of tell us who people are willing to listen to, then the next step is understanding what people do in response to challenges and then how we can respond in the positions that we're in to kind of keep building that trust. And that's the final part of what local research like this can give us. It can kind of show how people are navigating the system on the ground, their actual coping strategies, workarounds, so on and so forth. And again, this matters because if we want to design better programs, we have to build from what is actually happening. And so in our case here, we did see that people in their kind of responses to how they engaged with overcoming health challenges, some responses did show a lot of resilience, traveling to other cities, relying on social networks or using public programs. But kind of echoing that theme I've mentioned previously, oftentimes these were kind of co-occurring with strain or difficulty. So people revealed, for example, kind of difficulties using emergency rooms instead of routine care, and that adding a cost burden, or people enduring financial hardship from the cost associated with having to travel to another city for care. Ultimately, many people even reported kind of feeling hopeless or taking no action, which, as many of us know, has downstream effects for health outcomes in the long term. If people aren't getting treated now, that can make their conditions worse later. And so I think that these insights can help local organizations design supports that kind of meet people where they are and fill gaps where they need to be filled. And I think in this way, we also explored what shaped people's positive or negative experiences, maybe kind of what made them feel better or worse about having to kind of undertake some of these actions to overcome challenges. I think encouragingly, people described things like respectful, supportive individual encounters with providers and with the health system as kind of what shaped their trust and satisfaction very positively. I think on the other hand, they often noted things like perceptions of profit over quality care, misdiagnosis rates, or kind of a lack of holistic approaches as things that shape their negative encounters kind of with the health system. And so I think great news for all of us is that a lot of these types of things are addressable at the local level, through things like training for providers on communication techniques, incorporating patient-centered approaches into our work, or even just small changes in how our services are delivered day to day. And I think that these things are relevant for us, regardless if we're in clinical settings, if we're more in service-oriented settings. We can kind of take these broad themes into account and how we are working with our clients to just make sure that we're giving them these things that help feed positive experiences with the health system and kind of shape behavior over time. So just to sum up kind of what we've talked about, we can see how community-oriented research, findings such as those from our project, can do a few very useful things. First, they help to connect local voices to state and national trends, so we can kind of see where strategies, trends align or don't. These types of findings can show where exactly trust lives, where it can be strengthened, pointing to entry points for just better, more scalable partnerships and reach. And finally, they can just underscore really that need for meaningful, informed, bi-directional community engagement, because programs work best when they are rooted in how people are experiencing the challenges at hand. So, ultimately, research alone cannot solve these challenges, but it can give us a foundation for better work. And cross-sector work, I think, is really key to turning these insights into impact. So with that, I am very excited to shift to our panel discussion. Each of our panel members has engaged with us in the context of this specific work, but each of them also brings their own wealth of experiences working in rural and other public health contexts. So I am going to ask each of our panelists to briefly introduce themselves. I think one of our panelists, Dr. Sexton, I don't know if she's online yet, but if she isn't online, she'll get a chance to introduce herself. But I'll have the others introduce themselves first, kind of talk about their interests very briefly, and then after that, I will be asking them to share some insights from their experiences, but I will also be encouraging all of our attendees to do the same, commenting in the chat with questions, with comments. We'll be posing some questions out to you. So we are just very excited to hear from everyone, share experiences, and with that, I will let Mr. Russell Hopkins introduce himself.
Good afternoon, everyone. I'm Russell Hopkins. I'm director at Northeast Texas Public Health District for the Public Health Emergency Preparedness Program. I cover 7 counties with this program. We do disease surveillance, strategic national stockpile planning, and then other sorts of health and medical, or the Emergency Services Function 8 planning efforts for our local counties. Net Health is a bigger organization, particularly our WIC program, which the research relied upon, has operations in 20 counties and that across East Texas. So we were able to speak to a lot of moms, a lot of specific questions about preparedness and things that particularly interest me as we combine that with data from health outcomes across our area. We have questions. Why is our health outcomes worse than, say, the Texas Panhandle when our preparedness levels are higher? Things generate a lot of curiosity, and this has been a real gem of an opportunity for the department to ask more questions beyond those survey questions that were asked. We are now using data that we've generated in our coalitions, our Healthy Baby Coalition here locally. So we've really enjoyed participation in it, and it really, I think, informs us a lot of how Net Health proceeds in the future.
Thank you so much, Mr. Hopkins. I don't know if Dr. Sexton is on the call just yet, but maybe Dr. Patrick, if you could briefly introduce yourself and your interests.
Yeah, sure. I'm Dr. Stephen Patrick. I'm professor of obstetrics gynecology, vice chair for education here at the School of Medicine, UT-Tyler School of Medicine. And a quick shout out, I see a bunch of my colleagues from UT-Tyler online, so thanks for joining. When I started at UT-Tyler a couple of years ago, it was to help establish the Department of Obstetrics and Gynecology. And you may be familiar with the reason the legislature put us here at UT-Tyler is because there's just a lack of resources and lack of public health information and projects to address our healthcare disparities. So one of the first things I did when I started here was say, can you show me the data? I need to see data about outcomes in our area. And unfortunately, there's just not a whole lot of data. And so Dr. Sexton and I met each other here at UT-Tyler about a year ago, and the two of us put our heads together. She's actually an epidemiologist here at the university. And we put our heads together to start looking into what is available data-wise so we can start addressing our healthcare disparities. And so Dr. Sexton has networked with Texas State, and I've networked with some people at the state level, and we found out that, yeah, we know our maternal mortality rates are high here. As a matter of fact, they're on par with some of the countries in Central America. So we are losing way too many women because of complications of pregnancy. So as we looked into that, we realized we just don't have any data. So we have started a very large project that we're calling MNET, the Maternity Network of East Texas, which is helping to bring together a lot of partners. A lot of you are online, I see too. A lot of partners across East Texas to help us find out what's going on here locally, and then to develop projects to develop our healthcare disparities.
So I think that is such a wonderful transition kind of into our first topic. So before I pose some follow-up questions to Dr. Patrick along those lines, I would love for if everyone in the chat might just kind of make some comments about what trends you have all seen in your communities. You know, you may not be from East Texas, you may be from elsewhere in Texas or even from another state. So if you could just talk a little bit about some of the trends that you're seeing in your area, kind of do they align with some of the themes that we've been chatting about here? That would be wonderful. And maybe Dr. Patrick, if you could expand a little bit more on your data gathering project to kind of talk about how local data can be either help or challenge maybe to broader state national data, kind of just talking a little bit more about your program in particular and kind of the what you hope to gain from better data, better regional local data.
Yeah, well, basically the data is not out there. I mean, I personally, from my practice here, see that we have really high rates of diabetes, really high rates of hypertension and hypertensive disorders of pregnancy. And as a result, we're seeing, really bad pregnancy outcomes and an excess of maternal deaths. So as we were looking for the data, we just realized it's just not there. I can give you the example of the Texas Maternal Morbidity Mortality Review Committee. They look at all of the maternal deaths across the entire state of Texas, and there are 200 plus maternal deaths per year. They are overwhelmed. They do not have the ability to analyze every single death. As a matter of fact, they had to skip a couple of years because they were so backlogged that they just gave up on the data for a couple of years. And they started over again with 2024, I believe. But so the problem is they're not able to even get enough data to analyze the problem statewide. So they can't give us information region-wide. So I went to the committee chair and said, what's going on in East Texas and how can we help you? And my answer was, from her was that we don't have the data. I can't help you. You're on your own, basically. So then that's when we started looking to see what could we do locally at the university level to find the data. And so Dr. Sexton has been working with several other brilliant minds here at UT-Tyler and some large corporations to develop a database. And so we are in the process of developing an enormous database that will cover our Northeast Texas region. And that database then will be accessible to researchers, to healthcare providers, so that we will be able to then look at what's out there. For instance, I mean, I can't even tell you how many women have hypertensive disorders of pregnancy. When this database is up and running within the next year, we will be able to query it and say, find us all the cases of hypertensive disorders of pregnancy. Where are they? Which counties are they in? Find us all the maternal deaths that have been reported. Tell us what counties they're in. Tell us the cause of death. We'll be able to get that information on the regional level. So then I've approached the chair of the State Morbidity and Mortality Review Committee saying, hey, can we do this for you regionally? And the answer was an absolute yes. So
It's encouraging.
That's
I thought for a minute you were going to say no, and then I was going to
no,
feel a little nervous.
no. As a matter of fact, she told me, she goes, if you can get this regional model up and running, she goes, we will promote it to the state. The problem is the legislature has only appointed the state committee and not regional committees. So if we can develop a model locally looking at not just mortality, but we need to look at morbidity. We need to see near misses, sentinel events. We want to see the maternal deaths, but we need to find the near misses because that's how we can prevent maternal deaths. So she has asked that we develop this and get it up and running and then bring it to her and she'll present it to the legislature. So that's one big thing that's coming out of this database project. And of course, the counties, there's so much disparity in healthcare in all the counties. And like you've mentioned, the patients can't get to the physicians and then they may not trust them because they're not from the region and so forth. But as soon as we get enough information, we can actually take that information to the counties through local WIC offices, through Net Health and so forth, and their resources, so that we don't have to worry about patients coming up to us. We can take our project, our programs, our outreach, educational programs and so forth to the community. So the bigger project that we're calling the MNet is actually based on this database, and it includes partners such as providers, patients, insurance providers, and researchers. And this whole large MNet will be providing us with hopefully an abundance of data within the next year.
I think that that is so exciting. And I think that that is such a great use case for kind of how cross-sector work in a regional context can scale for impact. You know, how we can trial something on a more local level, work out the kinks, make sure we kind of have the relevant actors at hand, and then present it upwards. And, you know, I think maybe sometimes some people might have this impression, well, there's not a lot of value to working in a smaller area, or what can we really get because, you know, oh, is every community just itself and we can't, you know, make these broader trends, or we can't associate it back to anything. But I think that's such a wonderful use case of how things done in a local context can be, you know, set up, scaled up, and then adapted, you know, across a wider reach. And I would actually love to hear from Mr. Hopkins about maybe have you done similar kind of scale up work or things of that nature, maybe in some of the emergency planning, or just kind of preparedness things that you've done, or maybe how has some of the kind of data work that Net PhD has done, how has that maybe been a good use case or good model for things that could be replicated elsewhere?
I'm going to reference a program called Centering Pregnancy. You Google that. That's a program that will have high impact after a successful use here locally in Smith County, one of the urban counties of the Region 4-5 North. That effort done in Mount Pleasant or Pittsburgh in Northeast Texas, or Rusk, Alto, where there is access, that scaling up will then have a multiplying effect in a rural area. It isn't hard for us to fill those courses up. That program has a limited number of slots you can put in, but if that same number out in a rural area really does make a difference. And, you know, as I was saying earlier about having this research driving some of the information, that's one of the programs that I know our Healthy Babies Coalition and WIC program, they're all behind because it will translate into impacts out in the rural area.
Yeah, thank you. Thank you so much. I think that that's another great example. Kind of before we move topics, I would love to know from either or both of you, what specific local data, you know, could be interesting or useful. So we talked a little bit about just, you know, the rates of certain types of things, the location of certain types of things. Is there any sort of just maybe behavioral data that would be interesting, or any other sort of place-based data that you think could be useful in this context? I see a few comments in the chat, just kind of talking about, for example, you know, in the context of maternal health, like maybe lower likelihoods of attending first prenatal visits, maybe trying trying to get the message out kind of the importance of prenatal care or just sort of health and well-being through churches and things like that. So in your experience, what other kind of local data could be useful in just thinking about these types of health challenges, not just maternal health challenges, but just in general?
I can give you an example using the maternal mortality. I was at a meeting and I met with a gentleman from Louisiana, and he said, just across the Sabine River in Louisiana, the #1 cause of maternal mortality is drug overdose. So, we have zero information about that, and our mental health care services are limited as well. So, we could find out that 100% of our maternal deaths are due to drug overdose. That, of course, would direct our interventions in one direction, or we may find out that they were automobile accidents. Our educational outreach will extend in a different direction. So, there's just so many things that we don't know about. And this is where working with our local partners, I'm a member of the Healthy Me, Healthy Babies Coalition and several others. Those partners are able to tell us what they're seeing. Like I see somebody in the comments mentioned that not enough women are entering prenatal care in the first trimester. That's absolutely true. And we need to find those women so we can assess their risks for later on in pregnancy and for beyond. So there are so many things that we need to look at. And that's where this kind of meeting, the work that y'all are doing, thank you so much, because you're helping us to go and look at our needs. So one of our next big steps is to do our own needs assessment to find out what our various counties are looking for. And I'm glad, Russell, that you mentioned centering pregnancy. That's a great way to address a lot of these problems. And we're actually talking to WIC about potentially helping them develop some centering programs in some of our maternity deserts.
I love this. So I feel this is almost like everything is data, right? I think we're all learning from each other on where we could all maybe even plug in on these sorts of topics. So I think that maybe if something comes from this session, if anyone seems interested in any of the programs that are mentioned today, I think feel free to try to connect with one another in the chat, because I agree with Dr. Patrick. There's already a lot of crossover, I think, and a lot of synergy going on. I did notice that Dr. Sexton was able to join us, so I would love for Dr. Sexton to just give a brief introduction about herself and her interests.
Awesome. Thank you so much, Elizabeth, and really delighted to be here and joining at, I think, the perfect time. You mentioned data and I came running. My name is Dr. Jess Sexton. I'm a clinical epidemiologist at UT Tyler School of Medicine. I work closely with Dr. Patrick and Mr. Hopkins, and I'm very, very delighted to be here and to join the discussion as soon as we talk about data. Thank you, Elizabeth.
Yeah. Thank you so much, Dr. Sexton. So I think we'll kind of advance to the next topic. We've started to talk a little bit about it already. So if we could kind of put in the chat, certainly feel free to keep talking in the chat about what topics resonate with you. But if we could maybe think about here, have you all in your context, had good successes already from cross-sector partnerships or kind of cross-sector work that maybe marries research or data with some of your services? So I would like to extend out to the panelists the general question of, just in general, how can partnerships expand reach and improve outcomes? Maybe if you might share an example that's been successful, just so we have some examples of maybe success stories that can be motivating for the people who are in attendance today.
Absolutely. I'm happy to kick that one off. There are a lot of examples that come to mind, but the core of it is the people and the connectivity between the organizations. So in any instance where I've had the opportunity to work across sectors, for example, it's always started with people, and it's not necessarily in the environments that we would normally expect to have sort of normal social experiences like conferences or meetings. Sometimes it happens in places like the Healthy Me, Healthy Babies Coalition. Sometimes it happens when we share a call with someone to talk about a file transfer for a state report. So really leaning into our colleagues and the resources that they have and the wealth of knowledge that they have is really a beneficial thing. And to me has been like the lifeblood of community health and doing clinical research. The best example that I could think of from my past experience is the Center of Research Excellence in Stillbirth in Brisbane, Australia. It's a national organization, well, a national group that's based in one particular part of Australia that has a pretty high incidence of adverse pregnancy outcomes. And this group of people, you would think that we're just clinical researchers and we're academics, but it's really a multidisciplinary group of industry partners. But the underlying like golden thread are parents. So like in engaging with parent advocacy groups is one of the most, I would say, important things, because it keeps us aware of what the community needs are, and having that multidisciplinary, like truly multidisciplinary, like parent patient led programming really kind of keeps a lot of efforts like what you're describing on the right track. Like, so in my experience, a lot of my North Star, for example, have been expectant women in pregnancy, and talking about like adverse pregnancy outcomes in maternal health. You could do the same thing for diabetes and infectious diseases and STI screening. So making sure that your group of people that you're working with is not only connected but involves consumers, I think is one of the most important things that you can do to be successful.
I think that makes a lot of sense. I would love to hear also from Mr. Hopkins, maybe, because I also know that Northeast Texas Public Health District does so many different kind of community events, and they have their hands in a lot of pots. So I would love to maybe hear some success stories from there about how kind of these cross-sector partnerships have just kind of improved reach and maybe kind of better health outcomes for people in that region. Oh, let's see. Are we good? Oh, I think you might be muted. Let's see. Oh, let's see. Still mute. There we go. It's working now. It's good now.
Okay. So I'd like to maybe highlight the community behavioral health team that was formed here locally so that folks could get access to a primary provider for mental health care. And it is proven over the years that, we can spend a little money up front as a community and save a lot of money on the end. And what I find is we can do a lot of that with these other partnerships. I'm thinking of whether that be our kind of the mirror image of public health emergency preparedness is hospital preparedness program. So the HPP program, sharing that data back and forth, we know that, we can reduce trauma deaths. We can also reduce STEMI episodes to, minimal invasive procedures now. That's from bringing groups and partnerships together, driven on, this is the data, this is, in traumatic cases in East Texas, surprise, there's a lot of trees that people run into with their vehicle. And those kind of things can be brought up locally. Programs to either repeated or you originate a new one. And that's kind of what's been driving us locally, is using success to multiply that throughout. But I will say the difficult part begins when you start going out into the rural areas. And it really becomes difficult to deliver those services outside of an urban environment.
We had a quick request from Mr. Lambig, if you might be able to share any links to the community behavioral health program, or if there was a page or a report or anything on that.
There will.
Oh, that sounds great. I'm going to put just one question in the chat. I'd be interested to know just challenges that people have kind of had, maybe informing partnerships and maybe expanding existing partnerships. And maybe if our panelists could give some advice on what organizations can do to either kind of get started making these types of partnerships or expanding ones that they already have.
Yeah, can I comment? I see Sandra Brown made a comment, which unfortunately is a very big problem here in our rural areas, and that looks like Johnson County lost their only OBGYN.
Yeah.
Well, one of the ideas that we're floating out there is to provide virtual prenatal care. Fortunately, more and more people are connecting to the internet. And we have an interesting map in one of our presentations that shows internet connectivity is directly related to where you are, how close you are to the nearest interstate. So the closer you are to an interstate, the better internet connectivity you have. So unfortunately, a lot of our more rural counties are outside the interstates, but we do have WIC offices in a lot of those areas that have internet connections. So that's where we've thought about doing some kind of remote prenatal care. And there's even a model for remote centering pregnancy prenatal care. So we're looking to connect potentially locally through our WIC offices if we can get this up and running. So this is, again, UT Tyler could not do this on its own. We absolutely rely upon our partners. So that's just one idea that we've helped. And in Johnson County, I think that's Cleburne. That's outside our area, but I would suggest that you speak to the local medical schools. I know TCU now has a medical school, UNT has a medical school. Of course, there's always UT Southwestern. And then there's the Dell Medical School in Austin. So there are very likely other schools working on projects like this. And this is one of the problems we have too. Outside the UT system, we don't know a whole lot what's going on elsewhere. But I know Texas A&M has a big rural health project as well. Texas State does. So I think if you just get in contact with your local, large healthcare systems, especially through universities, to find out what they have going on.
I think that's a great point. Kevin had something, or Mr. Lambic had something he wanted to add quick.
Yeah, absolutely. And I echo no pun intended, I echo Dr. Patrick's comments on that. And I know that we have some folks on the call today from the Texas A&M Rural Community Health Institute. And, trust is one of the things that's mentioned in this study. And we see a lot of out-migration of care these days from small rural hospitals. So if a mom, either prenatal or post-delivery, is having a complication, if they don't trust the ER that they're going to drive the extra time to go to that large urban area. If we can catch some of those things early at the local rural hospital, then we would have better outcomes. I truly believe that. And that's one of the things that Texas A&M is trying to do right now with their program out of Archie, centered around maternal emergencies and preparing emergency rooms that don't have, a labor and delivery in that hospital, preparing them for maternal emergencies and what's going on there. So big one for that. The other thing about trust is this, the UT Tyler folks in the Southwest Ag Center, I know that Dr. Levine and Dr. Casanova are on the call. We partnered with them to do a program where they're taking, the other part about this is it's the patient, but it's also the provider part. And so, providers sometimes are just unaware of what their patients go through. And so we did a grant recently with SWAG around taking UT Tyler School of Medicine students into 5 different local projects to see what they were like. For instance, they go to a logging operation and they see, hey, what time does the logger have to get out of bed in the morning to get in the woods? And what's that work environment like? So when they see that logger in their clinic for an elevated, cholesterol and their A1C is up, and the first thing they do is, hey, you need to eat more fresh fruits and vegetables every day. And well, if you understand that the work that person is doing and where they're doing that work in, it's going to allow you to make a better plan for that patient. And so getting those experiences, and that also builds trust with the patient if the provider understands what's going on there. And so if they go to a manufacturing plant and the patient comes into them with some sort of a mobility issue, and you go and you visit the plant, and you see the repetitive motion that's going on there, but you tell your patient, hey, you need to take several breaks during the day at your job. Well, they're going to lose their job if they take a break in the middle of that. So trust is a big issue.
I think that's a perfect kind of transition into our last topic, but I think that's just such a great endorsement for how this change, can really be started and maybe even sustained at the local level. I think perhaps a lot of us are feeling a bit of pressure from maybe the resource or the funding environment at the moment. And it's not to say that, the burden of solving some of these solutions should just be on us at the local level. But I think, we should maybe take encouragement where we can, that we can make some improvements and changes in the local capacities in which we're working. And I think examples like, organizations or community organizations just reaching out to local medical schools, that's a great piece of advice. finding ways just to learn more about one another. I may call on Mr. Hopkins in a minute to kind of talk about some of just the less clinical community events that they do, because I think that they, from what I know of them, they really do kind of go towards this idea of building visibility and trust in the community. But I think that is really something to reflect on, because that is something that all of our organizations can do, and we can all do in our capacities, just as I said, when we're working with clients, when we're working with patients, finding ways to just understand one another a little bit better and understand the context in which we're all kind of living in. So if anyone wants to share in the chat kind of how these types of activities in their roles, organizations work has kind of helped to promote this trust, that'd be wonderful to hear. And maybe Mr. Hopkins can just kind of start us off about some of the kind of visibility programs that Net PhD has run in the local community to kind of just make a more positive, I think, impression of the health system and kind of the health services that are available.
Yes. So we do a lot of community outreach. We have a PIO, the individual who runs that, who Terrence Yates, my counterpart, who's extraordinarily good at communicating a message for us locally. And then we just take every opportunity we can, whether that is our first responders getting information at their worksite vaccine clinic this fall during their flu shot time, or if we're participating in School is Cool program to do backpacks. We also do vaccines there. WIC is going to be there. They're going to be giving information out about how dads can work with mom and the baby, bringing up a healthier baby. So that, and every opportunity we get to participate, whether that's at a WIC level with their specific programs, or whether we're going to the local Emergency Planning Council. Emergency Planning Council is something that we participate in locally that brings industry, academics, and local government together to do planning. And you know what, that's a great time to start talking to them about well-being and how you plan that into your organization, so you're more resilient to impact like natural disaster.
Thank you so much for that. I think that that's kind of a great note to sort of just transition to the last little bit of time to kind of open it up for some other additional audience questions. I did see one in the chat that I will answer quickly, just because I think it could be relevant to a lot of us. So we had a question, how exactly do I go about contacting people? How do I, find out sort of who's interested in what? And I would say that, a lot of our university web pages or organizational web pages, a lot of us do have kind of profiles up about the things that we're interested in. I know at Texas State, we're really encouraged to kind of keep those faculty profiles up to date. And I think at a lot of universities, it's the same. And a lot of times, we'll be listing the types of populations we're interested to learn more about, the topics that we're interested to work with. And I think many of us as researchers, we are always looking for motivated community organizations, either to do research or work at the organizational level. So kind of what makes your work successful as an organization, and also access to just different community participants, so we can, work together for that trust building. So honestly, I would just say, if there's a topic or area that you are interested in, you can search your university web pages, kind of search through faculty profiles, LinkedIn, ResearchGate is another kind of like sort of research-oriented LinkedIn website, where you can just kind of explore people's interests and reach out. I can tell you personally that I would be delighted to get an email from someone wanting to work with me and just sort of being excited in my interests. I would certainly, engage in a dialogue with that person. And I don't want to speak for our panelists, but I'm pretty confident they would also be excited for the same. And so I think that that's a great place to get started, to just, to reach out. A lot of us are willing to help. But is there anything else that people would like to share? Any other kind of pressing questions, positive, motivational success stories, big challenges that we can try to talk about in the last few minutes?
Elizabeth, I have one very quick, potentially motivational comment.
Oh, great.
Yes. So I think one of the things that I think can be intimidating, perhaps, because we're all human, is I think the best thing that we could do is to put ourselves out there. There are so many opportunities, and there are so many organizations that are doing incredible work. Like March of Dimes is a good example, and I would have never connected with them in the way that I do if it hadn't been for Russell's team and the Healthy Me, Healthy Babies Coalition. So even attending like a preterm birth awareness walk, you'd be so surprised at the number of folks that you'd be able to strike up a conversation with. And it can be, like I said, it can be intimidating, but we're all people, we're all trying to work for good things. And sometimes you just have to get out in the community, join your colleagues, and find new ones and reach across the aisle. And there's a lot of benefit from that. And there are some tangible tools available as well. So I have to absolutely plug the person. They have a lot of valuable resources for those who are leaning more into the community research space. They have a really vast network of community researchers that are available for consultations and support. And there's also the Episcopal Health Foundation. They have a CHCI program that I know one of our teams that's looking at diabetes, the CHW network of East Texas, of Northeast Texas. I know that they've engaged in that, which is connecting them with other sort of colleagues that are working towards health projects across Texas. So I suppose put yourself out there and keep looking for opportunities and lean into the resources that are available.
I think that that's a great point and a great way to close too, is just to kind of look at the things that are in our networks, in the things that we read, in our professional networks, our personal networks, in people's stories, just kind of listening, for the things that people are needing in our conversations in our communities, and that is a good way to get started. So I think with that, we want to be honest on everyone's time here. We truly want to thank you for being here today. I loved seeing all of the discussion and connecting going on in the chat. That was so encouraging. And so this is just session 1 of 3. We hope that you will join us for the next 2. You can mark your calendars. It is noted on the slide. The next couple of sessions are actually going to involve some speakers, some of them nationally renowned, to talk about kind of implementing programs in their communities and really how they were able to make a very large scale impact. So we are hoping that you will join us. If you could go ahead and also fill out a survey about our event today, we would be very appreciative. It helps us to design better content, more interesting content, and helps me be better. So that would be great. We're going to put a link in the chat. There's a QR code on the slide. And ultimately, we're so thankful that you were here. We hope you will join us for our upcoming sessions, and please get the word out. Forward your email registration, forward the information to your networks, your colleagues. Follow us on our social media for more details as things go along. The recording will also be available on YouTube if you just want to jog your memory about all of the wonderful things we talked about today. And once again, just thank you on behalf of all of us, all of our organizations, for your time and attendance today.